السادة الحضور مع حفظ المقامات، أسعد الله صباحكم بكل خير، وأهلا وسهلا بكم في رحاب كلية الطب بجامعة جابر بن حيان الطبية. يسرنا في هذا الصباح أن نستضيف ضمن برنامج الاستاذ الزائر الاستاذ المساعد الدكتور حيدر صالح الصفار العراقي الأمريكي، خريج كلية الطب جامعة الكوفة عام 2004. يقف أمام أساتذته القدامى، حاصل على شهادة البورد في الجاينيكولوجي، وحاصل على شهادة الماستر في الكلينيكال ريسيرش. يعمل الآن في كليفلاند كلينيك في الولايات المتحدة الأمريكية. سيتفضل الدكتور مشكورا بإلقاء محاضرة حول موضوع الأبديت on management of advanced stage ovarian carcinoma. فليتفضل مشكورا.
شكرا دكتور عادل. السلام عليكم. بالبداية أنا أحب أشكر دكتور علي الصائغ ودكتور عادل المياني على الفرصة أنه ألقي محاضرة خصوصا قدام أساتذتي وقدام الحضور. شكرا جزيلا. So I prepared two lectures. So one lecture I was planning to focus on surgical management of ovarian cancer. What is the update on surgical management of ovarian cancer? And the plan for the second lecture was to focus on the medical management. But what I'm going to do, I'm just going to go over both of them and just focus on the most important things for that. I just want to give you a little bit quick personal history about me. And so I graduated from Kufa University, and I'm really proud of that, being graduated from this city. And after that, I left to the United States, and I did my postdoc fellowship in immunology and cancer immunotherapy in Wayne State University, Karmanos Cancer Center. And then after that, I did my OBGYN residency in University of Washington in Seattle in 2012. And then I moved to Cleveland, Ohio, and I did my master in clinical research. And then I did my another postdoc research fellowship in cancer genomics and Genomic Medicine Institute in the Cleveland Clinic. And then I did my second residency, or you can call it fellowship, in gynecologic oncology at the Cleveland Clinic. What I do now, I'm an assistant professor at the Cleveland Clinic in the Department of Surgery, but I also direct the immunotherapy and G1 oncology genomic and immunotherapy program at the Cleveland Clinic. Oh, thank you. But I'm also part of the translational research group, because I also, 25% of my time, I do preclinical research. And the whole idea of preclinical research is to develop new therapies, new targeted therapy, new immunotherapy in ovarian and endometrial cancer by testing it in mouse models and looking at the novel combination therapy and looking at the genomic signatures and cancer genomic profiles to identify signatures that can identify patients who benefit from specific therapy. And then we move them to the phase 1 trials. I'm also a part of the phase 1 trial on the cancer genomic program within the whole cancer center. So what I'm going to focus on today is ovarian cancer. Ovarian cancer is the most lethal cancer in the United States. It's a deadly cancer because the majority of the patients are diagnosed at advanced stage, and the mortality rate is high. The problem with that, because we don't have effective screening tests, and most of the patients, we diagnose them at advanced stage. So if you compare ovarian cancer to cervical cancer to endometrial cancer, at least for cervical cancer, we have a screening test, pap smear. For endometrial cancer, we tend to diagnose endometrial cancer at early stage, at stage 1 disease, and we have a screening symptom, which is the bleeding. So most of the patients tend to have postmenopausal bleeding at earlier stage, so we tend to diagnose it at earlier stage. But for ovarian cancer, we really don't have an effective screening symptom or screening test. So that's what created the problem, and that's why it's a deadly cancer, because when we diagnose the patient, we diagnose them at the advanced stage. In general, ovarian cancer is divided into epithelial cancer and non-epithelial cancer. Epithelial cancer is the most common type of ovarian cancer, and my focus is going to be mostly about epithelial cancer. So in the past, what we used to do, and I'm not sure what you guys do here, in the past we used to grade ovarian cancer as a grade 1, grade 2, grade 3. But now we developed a new concept, especially in serous carcinoma. Now basically they are divided into low grade and high grade. And we realized that this is better grouping system, because really these two groups, low grade versus high grade serous carcinoma, they are different. They are different in their molecular profile, they are different in their genomic profile, they are different in their clinical behavior, and also they are different in the way we treat them. So if you look, patients with high-grade carcinoma, they tend to have P53, higher chance of having P53 mutation, but lower chance of having other mutation like KRAS and BRAF, but it's the opposite for low-grade serous ovarian cancer. My talk is going to focus mostly on the most common type, which is the high-grade serous ovarian carcinoma. What about the prognostic factors? So we know the stage is one of the prognostic factors. Advanced stage disease, patients who are diagnosed with advanced stage disease tend to have worse prognosis compared to those who are diagnosed at earlier stage. Patients with residual disease, because the main goal when we do surgery, the goal is to remove all the visible cancer, all the gross residual disease. So if you leave any disease, it is also adverse prognostic factor. Age, performance status, and also the cell type, because we know patients with serous carcinoma, they respond to chemotherapy, but patients with a clear cell, patients with BRCA mutation tend to have better outcome, better prognosis, and they respond better to chemotherapy. So, surgery. So what is the role of surgery? The most important thing about surgery is where to give the surgery. And I'm going to switch to the other slides in a second. But I just want to give you an idea that the most important thing is when you do surgery is how much disease you leave. The most important thing is basically to remove, if possible, to remove all the gross residual disease or any disease that's more than 1 centimeter. So we have one study that looked at the prognosis and the outcome in relation to how much disease you leave. So basically what they did, they divided the patient based on how much disease is left. So if you look, they divide them into less than 2 centimeter and more than 2 centimeter with different grouping. And what they showed that if you leave disease after you do your surgery, if you leave less than 2 centimeter disease, those patients tend to have better outcome. Then they went back and looked at the 2 centimeter, and they divided them into no gross residual disease, less than 1 centimeter, less than 2 centimeter, and more than 2 centimeter. And basically what they showed that if you leave no gross residual disease, those are the patients who have the best outcome. Then after that, less than 1 centimeter, and then less than 2 centimeter. And basically this finding was also confirmed in another trial. But now the way we classify them, we classify them into 3 classes: either complete resection, which means that no gross residual disease left, or optimal debulking, which is basically less than 1 centimeter, or suboptimal debulking, which is basically more than 1 centimeter. Sometimes when we say optimal debulking, we include complete resection and less than 1 centimeter, because the ultimate goal of surgery, if you decided to take the patient to surgery, the ultimate goal for ovary cancer, for advanced stage ovary cancer patient, the ultimate goal is to do optimal debulking, which either you resect all the gross residual disease or anything more than 1 centimeter and you keep less than 1 centimeter. So basically this trial showed that patient who had all of their gross residual disease was resected, they did the best, then those who had their disease left at less than 1 centimeter, and then the worst are those who have suboptimal debulking. Overall, the standard therapy for ovarian cancer, it's basically, for advanced stage ovarian cancer, it's basically surgery and chemotherapy. I think the question will be, when do you do surgery and when do you do chemotherapy? And this is a debatable question, and it's being studied in different clinical trials. And basically the idea, either you do primary debulking surgery, then you do chemotherapy, or you do neoadjuvant chemotherapy, then interval debulking surgery, then chemotherapy after that. It was studied in 2 phase 3 clinical trials. One is called the URTC trial, which was done in Europe and Canada, and the other trial is called CHORUS trial, which is basically done in UK. And basically these 2 trials, they did a randomized phase 3 trial. They compared primary debulking surgery, then chemo, versus neoadjuvant chemotherapy, surgery, then chemo. And basically what they showed that there's no difference in outcome. So if you take patient and you give them chemo first, or you do surgery first, the outcome is different. The progression-free survival, overall survival is the same. The only difference is patient, when you give chemotherapy first, they tend to have less extensive surgery, less chance of having organ resections. But we always debated that, and we always, in the United States, we critique these results for many reasons. For one reason, because we believe that they did not do maximum surgical effort. They were not aggressive enough in doing the surgical debulking. And the second part, because the reported outcomes actually, compared to our data, it's basically the outcome for suboptimally debulked patient, not for optimally debulked patient. Our data showed that patient, if you optimally debulk patient, those patients tend to do better. And I'm going to show you, I'm going to compare these data with the reported data so you can have an idea. And overall, we believe we're better surgeons than the surgeons in Europe because we are very aggressive compared to Europe. So in general, our standards is at the Cleveland Clinic, and in general, in most of the tertiary centers in the United States, is to consider a primary debulking surgery in all patients with advanced stage ovarian cancer if it's deemed to be feasible, and if the surgeon thought that it would be possible to do optimal debulking surgery. So we have specific criteria that patients should fit these criteria to consider surgery for them upfront, because we do know that this tend to be more extensive, but potentially associated with better outcome. So the criteria we have is basically age, and the patient should be under 80, regardless of their performance status or comorbidities, because we did studies on elderly patients, 80-year-old and more, and basically what we showed that just the mortality rate, just by surgery itself, regardless even the extent, the mortality rate is about 20% within 30 days. And it's part of it is just the physiology of those patients. So most of us basically recommend neoadjuvant chemotherapy for patients who are 80-year-old and more, except if they are very active, very healthy, basically will be individualized. The second part is performance status. They have to have good performance status. They have to have good nutritional status. We usually measure it by serum albumin or prealbumin. And also, they have to have under stage 4B disease. So usually it's stage 4, stage 3, and stage 4A we consider it because it's only the pleural effusion, but you have to judge it case by case. But usually for stage 4B patient, we treat them with neoadjuvant chemotherapy. And also, the most important 2 factors. Number 1, the surgeon has to believe that it's going to be possible to do optimal debulking surgery. It's going to be possible to resect either all the gross residual disease or anything more than 1 centimeter. It could be before surgery by assessing the CT scan, but also sometimes we think that we're going to do optimal debulking. We take the patient to the OR, and when we open them, if we felt that we're not going to be able to resect all the gross residual disease or anything more than, or optimally debulk, which means resecting any disease more than 1 centimeter, if we felt we are not going to be able to achieve that, we usually close the patient. We do not do any surgical attempt because there is no benefit of doing half of the surgery and doing suboptimal debulking, because those patients, they are not going to benefit from the surgical portion, and it's better to close them, have them heal quickly, and start the chemotherapy as soon as possible. And then you can take them back for interval debulking surgery after that. So these are the same question. They compared neoadjuvant chemotherapy, then interval debulking surgery versus primary debulking surgery followed by chemo with maximum surgical efforts. And basically, the design of the trial, because if you think about it, primary surgery is the standard. So if you bring a new modality as the neoadjuvant chemotherapy, you have to show that it is not inferior or it's equivalent. So the design of the trial does matter. So it's not a superiority trial, it's equivalency trial or non-inferiority trial. And with this trial, these trials tend to be difficult because you need larger patient to prove that, because it depends on the confidence interval. So what they did, they took patients with advanced stage ovarian cancer and basically they randomized them into either primary debulking surgery, then chemotherapy, or neoadjuvant chemotherapy, then interval debulking surgery, then chemotherapy. Basically what they showed, they were not able to show that neoadjuvant chemotherapy is not inferior to primary debulking. And they ended up, basically the conclusion of the trial is that they concluded that they cannot say that neoadjuvant is equivalent to primary, and primary debulking surgery should be always the ultimate goal, and then neoadjuvant chemotherapy will be recommended if it's deemed that it's not possible to do the primary debulking surgery. But the other interesting thing also, what they showed, that they confirmed the prior studies, which basically showed that optimal debulking does matter. So patients who had optimal debulking surgery and who had their cancer resected to no gross residual disease, they did the best compared to those who had residual disease. And then what I wanted to show you here, you see the two trials I just talked about, this one, the URTC and CORALS trial. But if you look at the other trials that we did in the United States, if you look at the overall survival in general, it's in the upper 50s to 60 months. But these trials are low. The overall survival is in the 30 months. And if you compare our trial that looked at suboptimally debulked patients, it's about 26 to 38 months. So these basically data, these numbers are close to suboptimally debulked patients. That's one of the reasons, that's why we criticize these trials. And basically the study that I was just talked about, the Japanese trial, basically confirmed these findings that we still cannot say neoadjuvant chemotherapy is not inferior to primary debulking surgery, and more trials are needed. So I just talked about the primary outcome was overall survival, and this is the design of their trial. Basically, neoadjuvant chemotherapy, then interval debulking, then chemotherapy versus primary debulking, then chemotherapy. And if you look also here, this is also confirmed that they did maximum surgical efforts. Because the average blood loss in the primary debulking patient was 3.5 liters compared to 600 cc's. And also the average time was 340 minutes for the surgery, and about 1/3 of the patient had multiple organ resections, which give you an idea that those surgeons were aggressive, and that's potentially why they could not show that these two arms are equivalent. So basically, in conclusion, we still cannot say neoadjuvant chemotherapy is equivalent to primary debulking surgery in all patients. We have two trials, which you can use as a reason to give neoadjuvant chemotherapy. So people who argue toward doing neoadjuvant chemotherapy use these trials, and I think it's a reasonable approach, But you have to understand the limitation of these trials and also the finding of this new Japanese trial. And the other side, the people who advocate for primary debulking surgery, they use the critiques on these trials. And also there is other theories that basically if you remove the bulk of the tumor, you potentially can remove the resistant clones of the tumor, and also you increase the growth fractions of the tumor, so potentially they can respond better to chemotherapy. We are, in the United States, we are designing a trial. It's starting in Memorial Sloan Kettering, and basically what they're doing, they're selecting tertiary centers who are known for being aggressive with surgical management, and basically we're looking into that question in the United States in a clinical trial. So hopefully we'll have this done and settled. The other thing I wanted to talk about quickly is, before I go to the chemotherapy part, is actually I'm going to talk about two things. Number one is what is the role of, so you have a patient who was diagnosed with ovarian cancer, let's say had surgery and chemotherapy, and then basically went into remission, and then the cancer came back, And what do you do for those patients? In general, we do chemotherapy if they are platinum sensitive, which means if their cancer came back after 6 months after their prior platinum therapy. There's some studies show that there's benefit for doing surgery for those patients, but it's not for everybody. It's for selected group of patients who have oligometastatic disease, have good platinum-free interval, and no ascites, and have good performance status. So we have 2 phase 3 clinical trials try to answer this question. The first trial is a European trial, and it was presented last year in 2017 in ASCO meeting. And basically what they did, they took patients with recurrent ovarian cancer, and they randomized them into either surgery then chemo or chemotherapy alone. And basically what they showed that there is improvement in progression-free survival in those who had surgery in the selected group based on specific criteria than chemo compared to those who had chemotherapy alone. So this kind of support that if you have a patient, recurrent cancer, fit specific criteria for surgery, they benefit from surgery, resection of tumor, than chemo. But we don't have overall survival data on this trial yet. And one of the critique on this trial is basically you are resecting the tumor. So you are intentionally delaying the time to recurrence because you're removing the bulk of the tumor. And the critique is progression-free survival as a valid endpoint, or maybe we should look at overall survival because that's what matters. So the other interesting thing about the trial was they showed that if you decide to do surgery for patients with recurrent cancer, the goal should be always to resect all the visible cancer, all the gross residual disease, because what they're showing here is, if you see the higher curve is those who had no gross residual disease at the time of surgery. But if you left any tumor, actually they don't benefit, and their outcome is similar to no surgery. So the aim should be always to resect all the gross residual cancer. Then we tried to replicate this trial in the United States. So it's kind of basically the same design, but the difference is to avoid the critique. The difference is to look at overall survival, not progression-free survival, and see if you do surgery, then chemo, does it improve overall survival compared to chemotherapy alone? And basically, this is the trial design, and basically surgery versus no surgery, then chemotherapy after that. And what they showed that, number one, that the majority of the patient had no gross residual disease, which we call it R0. About 2/3 of the patient ended up being cytoreduced to no gross residual disease. But the interesting thing is they showed that there was no difference in progression-free survival and no difference in overall survival between those who had surgery and those who did not. So what they did, they went back and looked only at patients who had no gross residual disease, the R0 patient, which is about 2/3 of the trial. And they showed that, as expected, those who had R0, they're better than those who had no R0, who had residual disease left. They had better survival, better progression-free survival, and better survival. But when they compared it to no surgery, those patients had improved progression-free survival, which is consistent with the other trial, but there was no difference in overall survival. So basically, the trial did not meet its primary endpoint because it did not show improvement in the progression-free survival or overall survival overall, and it did not show improvement in overall survival in the R0 subset. The last part I'm going to talk about, I talked about extent of primary debulking, so I'm going to skip that part. The last part I'm going to talk about for the surgical portion is the role of heated intraperitoneal chemotherapy. It's a new concept, and basically the idea of using heated chemotherapy at the time of surgery is to augment the response to chemotherapy, because we know hyperthermia increases the penetration of the chemotherapy into peritoneal cavity, improve response to chemotherapy by enhancing DNA damage. Also, hyperthermia itself can cause direct cytotoxic effect by causing DNA damage and by activating heat shock protein response, which potentially can have anti-angiogenesis effect and also activate natural killer cells. So I just want to walk you over that. So basically, what we do it at the time of primary debulking, at the time of debulking surgery, which is the interval debulking surgery, mostly we do it. Basically, we put two catheters, the inflow and outflow catheter. Usually, we put the outflow catheter by the liver and the inflow catheter directed into the pelvis. And then we close the abdominal cavity. We close only the skin. And then we infuse saline into the abdominal cavity. We fill the abdominal cavity with saline through a pump with a heat exchanger. And we increase the temperature to 40 Celsius. And then after we increase the temperature to 40 Celsius, this is kind of circulating in and out. After we increase the temperature, we start the chemotherapy, which usually we use cisplatin, 75 to 100 milligram per square meter for about 1.5 hours. And then we open the patient, we irrigate, and we close. We started also doing it with patients with laparoscopic surgery, especially when we do laparoscopic interval debulking. We can put the catheters through the laparoscopic port, and we can do the same thing. The data for that, we have a clinical trial that was just presented last year in ASCO, and basically the clinical trial compared the interval debulking surgery with hipec versus just interval debulking surgery. So they took patient advanced stage ovarian cancer, had 3 to 4 cycles of chemotherapy, then they randomized them into either debulking surgery with hipec or just debulking surgery. And what they showed that there is an improvement in progression-free survival and overall survival. If you look at it, there is about 12 months improvement in overall survival if you get hipec with surgery compared to just surgery alone. At the same time, there's another trial presented. The difference is this trial looked at all patients, whether you have primary debulking surgery or interval debulking surgery. And basically, this trial showed no benefit. But when they went back and looked at subset, primary debulking versus interval, they showed that there is a benefit in the subset who had interval debulking surgery, which basically confirmed the result of the other trial that the hipec is beneficial for patients who had interval debulking surgery, but it has no benefit for primary debulking surgery. And that's why now what we do, we now combine hipec with interval debulking surgery, but we don't do it in the primary debulking surgery. We also do it in selected cases when we do secondary debulking surgery. When in recurrent cancer, we do debulking, and then we do the hipec. So I'm gonna skip the surgical part and go to the chemotherapy part. Up to this point, any question? Before I talk about the chemotherapy part. I'm going to talk briefly about the chemo and then go over more like about immunotherapy and targeted therapy. So just to give you an idea how we started with chemotherapy for ovarian cancer. So this trial is in 1996. It's called GOG 111. So GOG is a G1 gynecologic oncology group, which is kind of the higher committee that oversee all the clinical trials that we do for gynecologic cancer. And this is a randomized trial, basically looked at cyclophosphamide cisplatin versus paclitaxel and cisplatin. And basically this trial showed that there is improvement in progression-free survival and overall survival when you use cisplatin and Taxol compared to cisplatin and cyclophosphamide. And that's why the standard of care at that time switched from cyclophosphamide cisplatin to cisplatin Taxol. Then in Europe, they did similar study. It's called ICON 2. So everything starts with ICON, is usually a European trial. And ICON 2 basically confirmed the same result. The main issue with cisplatin is a very toxic drug. It can cause nephropathy, neurotoxicity. So we tried to replace it with less toxic drug. It's called carboplatin. They are basically the same class, but it's better tolerated. So GOG 158, it's a non-inferiority trial that basically compared paclitaxel cisplatin with paclitaxel and carboplatin. And the whole idea of the trial was to show if this new regimen is as good as paclitaxel cisplatin, but is less toxic. And basically what they showed, they met their primary endpoint, and basically they showed that the two regimens are equivalent, but carboplatin and Taxol is less toxic. So this led to change in standard of care from cisplatin Taxol to carboplatin Taxol. And you know, one of the side effects of Taxol is neurotoxicity and neuropathy, and it's not applicable for all of our patients, especially in patients with diabetes who have residual neuropathy. So we need an alternative for a drug in the same class but different drug. So we have a drug called docetaxel or Taxotere. It's the same class as Taxol, but it causes less neuropathy, but it causes more neutropenia. So the European group, they did a trial to compare carboplatin and Taxol versus carboplatin and docetaxel, and their primary endpoint was progression-free survival. And basically what they showed that there was no difference in progression-free survival. So what we do now, if patient has residual neuropathy, they cannot take Taxol, we offer them carboplatin and Taxotere. Then after that, we try to see if we can do something different to improve the outcome. So this trial is a GOG 172. It's a phase 3 trial that looked at IV chemotherapy versus combination of IV and intraperitoneal chemotherapy. And what they did, they compared paclitaxel with cisplatin compared to paclitaxel IV IP and cisplatin IP. And what they showed that there is improvement in overall survival when you give chemotherapy intravenously and intraperitoneally compared to intravenously alone. And this led to the National Cancer Institute alert about the outcome of this trial, and then after that, this regimen was approved. So now what we have 2 regimens approved. I'm talking like at that time. We have IV carbotaxol, and we also have IV IP cisplatin and Taxol. So after that, we try to answer the question, can we add more chemotherapy? So we're doing 2 chemotherapy. What happened if we did 3 chemotherapy? Do we improve outcome or not? So GOG 182 basically tried to answer this question. And what they did, they took the backbone, carboplatin, Taxol, and they tried to add third drug, gemcitabine, topotecan, and also Doxil. But unfortunately, this trial did not show any improvement in progression-free survival or overall survival when you add a third chemotherapy. So basically, 2 chemotherapy is good. If you add a third chemotherapy, there is no benefit. So that's adding a third chemotherapy. What about adding a biologic therapy? We have a drug called Avastin or bevacizumab, which is a monoclonal antibody that works at the VEGF receptors, and its main function is to have anti-angiogenesis activity. And we have this phase 3 trials, and basically it has 3 arms. It's called GOG 218, and they use the backbone, which is carboplatin and Taxol, and then in the arm 2, they gave Avastin only with chemotherapy, and with arm 3, they gave it with chemotherapy and then maintenance therapy after that. And what they showed that if you give Avastin with chemotherapy and then you continue it as a maintenance therapy, there is improvement in a progression-free survival. There is about, it depends on how you look at it, there is a 4 to 6 months progression-free survival benefit, but there was no overall survival benefit. And this basically led to FDA approval of Avastin in combination with chemotherapy, then as a maintenance therapy for a year in patients with advanced stage ovarian cancer. Now, the other question is, what about the dosing schedule? So we give chemotherapy, carboplatin and Taxol every 3 weeks. What if we give it every week? There is some preclinical data and phase 2 data showing that if you give Taxol weekly in dose-dense fashion, it can have anti-angiogenesis activity, and you probably don't need Avastin for that. So this is a Japanese trial, and what they did, they looked at the traditional carboplatin and Taxol, and they compared it to every 3 weeks, and they compared it to carboplatin every 3 weeks and Taxol in a dose-dense fashion, which means 2 things about dose-dense fashion. It's you give it every week, but you give higher dose. You give 80 milligram every week. And what they showed that there was improvement in overall survival and progression-free survival. So if you look at overall survival, there is a jump from 62 months to 100 months. So patients who had every 3 weeks, their median survival was 62 months, and it went up to 100 months if you give dose-dense therapy. What they tried in Europe, they tried to replicate the trial, and basically what they did the same study, but they lowered the dose of Taxol from 80 milligram, the weekly Taxol, to 60. And because of that, unfortunately, they did not show any improvement in the progression-free survival or overall survival, which basically means there is role for the dosing regimen. It's not necessarily the schedule, it's the schedule and the dosing regimen. In the United States, we did replicate the same trial, but we tried to incorporate Avastin into it. So we wanted to answer the question, if you do carboplatin and Taxol plus minus Avastin versus carboplatin and weekly Taxol plus minus Avastin, do you improve outcome or not? And basically what we showed that there is no benefit if you add Avastin to carboplatin and Taxol every 3 weeks, there is no benefit of doing dose-dense therapy or weekly Taxol. But if you have a patient who cannot have Avastin, they do benefit from doing dose-dense weekly Taxol. So basically the summary, if you give carboplatin and Taxol every 3 weeks and you add Avastin, there's no benefit of weekly Taxol. But if you cannot give Avastin, or you don't want to give Avastin, or it's expensive, those patients benefit from dose-dense weekly Taxol. This trial basically tried to answer another question. Tried to answer, can we incorporate dose-dense with intraperitoneal chemotherapy? Is it better compared to just intraperitoneal chemotherapy? And basically, this trial showed no difference if you do dose-dense with intraperitoneal. So I just talked about neoadjuvant, so I'm just going to skip on that. I'm going to skip on that. The other part I want to talk about is the role of immunotherapy. It's an emerging field, and basically, immunotherapy, it's utilizing the immune system to fight the cancer. And we know cancer cells are smart cells. And what they do, they produce certain receptors on their surface. The most important one is called PD-L1. And these tend to interact with T cells and suppress T cells. So our immune system cannot fight the cancer. There is emerging evidence about the role of monoclonal antibody that goes and block these receptors, block PD-1 and PD-L1. And once you block this receptor, you block the interaction between the cancer cells and the immune cells, and by this way you boost the immune cells and you improve their response to immunotherapy. This field is progressing very rapidly in melanoma, and now we have immunotherapy approved as a first line in melanoma, and also in lung cancer and renal cancer. In ovarian cancer, we have some data about the role of immunotherapy with modest response rate. If you look at the data, overall the response rate is about 10 to 15% using different immunotherapeutic agents. So we have nivolumab, which is a PD-1 inhibitor. We have pembrolizumab, it's a PD-1 inhibitor, and avelumab, which is a PD-L1 inhibitor. Overall, the response is about 10% to 15%. Recently, a phase 2 clinical trial, it's actually a large phase 2 clinical trial, they looked at the role of pembrolizumab in patients with recurrent ovarian cancer. And what they showed, what they showed here, overall the response rate is 8%. So it's not that high, but what they did, they showed two things. Number one, even if you don't have response rate, those patients can have stable disease and they can have a shrinkage of their tumor. So about 1/3 of the patient had some benefit. And if you have some response, or some benefit from immunotherapy, this response can be durable and can be long lasting. The other thing they did, they looked at the PD-L1 expression. Because you remember we said tumor cells express PD-L1 and interact with PD-1 on the immune cells and block it. So it makes sense to target the tumor cells that express PD-L1 because it will work better. So what they did, they stratified based on PD-L1 expression. If you look at the last square, you see that by PD-L1 expression, if you express more PD-L1, you have better response. So if you don't express any PD-L1, it's about 4%. If you express some PD-L1, it's about 10%. But if you express high amount of PD-L1, the response rate goes to 17%. So there is some data showing that there is potential role for immunotherapy. Now what we do, we use immunotherapy as a second line in patients with platinum-resistant recurrent cancer, but also we are looking at it as upfront therapy and platinum-sensitive recurrent cancer in combination therapy, because we understand that as a monotherapy is not very active, but it potentially could be more active when we put it in combination therapy. So as part of my research, what we did, we tried to look at the tumor and do next generation sequencing and identify genomic signature that can identify patients who respond better to therapy. So what we did, we looked at 18 gene signature, which is basically looked at, we call it interferon gamma gene signature. And these are the list of the genes. And these are involved in inflammatory response, T-cell response. And basically this one has been looked at in melanoma, head and neck, and gastric. So we went back and looked at it in our cancer, and we showed that this signature actually predict prognosis and predict response to therapy. And a patient who had the signature had better progression-free survival and better overall survival. So what also we did, we tried to create our own signature. So we divided the patient who did well and the patient who didn't do well, and we created 16 gene signature, and we're trying to validate it now in a larger sample size. The last two things I'm going to touch on is the combination therapy. You remember I talked about the fact that immunotherapy by itself doesn't work well, so it's better to combine it. So there is a lot of option for combination. So I'm going to just talk about two trials that looked at two combination options. One is to combine it with PARP inhibitors. And basically it makes sense because PARP inhibitors also as a targeted therapy, and it prevents the cancer cells from repairing their single strand break in the DNA, and if they cannot repair it, they can accumulate the damage and die. And it's especially more relevant in patients with BRCA mutation because those patients cannot repair their double DNA strand breaks and rely on single strand breaks repair. So when you cause DNA damage, you cause more release of a new antigen and increase the antigenic load and increase the response to immunotherapy. So this trial basically showed that in patients with recurrent platinum-resistant ovarian cancer, the response rate is about 25% when you give a combination of immunotherapy and PARP inhibitors, and which is really good. The specific part, we have a specific group of patients, we call them platinum refractory, those who progress on primary chemotherapy. And they are very difficult patients to treat, and overall they don't respond to anything. And in this trial, they showed that the response rate is about 24%, which is really impressive. So this is an impressive regimen to combine immunotherapy with PARP inhibitors, and there's a lot of trials ongoing to look at this regimen. The other approach is to combine two immunotherapy, so to block two receptors, maybe you can get more benefit. So beside PD1, PD-L1 interaction, there is another receptor, it's called CTLA4. It's another receptor that also regulates the immune response. And the theory is if we block both, maybe you will have better immune response. So this trial basically looked at the combination of both, and what they showed that if you give just one drug, the response rate was 12%, but if you give the combination, the response rate was about 31%. Not only that, if you give the combination, also you have increase in progression-free survival from 2 to 4 months. So this is also another regimen that's been understudied. The last thing I'm going to touch on is the role of PARP inhibitor. It's a new emerging therapy, and basically it's more relevant in patients with defect in their DNA repair, especially patients with the BRCA1 and BRCA2 mutation. And we have a clinical trial that looked at the role of PARP inhibitor as a maintenance therapy after you finish chemotherapy in patients with ovarian cancer compared to placebo. And basically the trial showed that there is improvement in the progression-free survival regardless if you have BRCA mutation or not, but the benefit was more prominent in patients with a BRCA mutation. So I'm done with this part. And then the last part I'm going to talk about, I have some surgical videos if you want me to show them. So just to give you, this is a case I did for one of my patients, and we prepared it because we submitted for a conference. This patient basically had she had endometrial cancer. I did her first surgery. She went for 2 years. Oh, thank you. She went for 2 years, and then her cancer recurred. And she had a vaginal mass at the vaginal cuff, which was invading the rectum. So what I ended up doing, I did the Da Vinci-assisted laparoscopic rectosigmoid resection in the block with the mass and upper vaginectomy and the primary reanastomosis.
The patient was a 16-year-old female with stage 1 endometrial cancer. She underwent original staging surgery July 2015. Neoadjuvant therapy was indicated or administered. She presented to a routine follow-up about a year and a half later with abdominal pain, constipation, and bloating. Serum P5 was elevated, and imaging demonstrated a 5-centimeter vaginal recurrence of vaginal sigmoid colon involvement. Decision was made to proceed with primary resection. As such, traditional laparoscopy was first undertaken to ensure no disseminated disease was present. The vaginal cuff can be initially adhered to a sigmoid colon and left pelvic peritoneum. The Da Vinci robotic platform was then docked and circular resection begun. Attention was first turned to.
I can explain that better. So basically what I did, I opened the left pelvic side wall peritoneum and I identified the ureter. You see the moving part, and I mobilized the ureter to the left side. And they went and they did the dissection around the mass to mobilize the colon and also to get into the pararectal space and to get into the rectovaginal space, because the goal is to remove the mass in the block with the rectosigmoid. So that's the dissection on the left side. And I did the same thing on the right side, basically also opened the pelvic side wall. And then the second part is to get the ureter off, the bladder off. So I dissected the bladder to get it off the vaginal area, and so I can get the upper vagina along with the rectosigmoid. And in this part, I'm just creating, I'm having the assistant put the EA sizer to identify where's the rectum, and so I can identify the rectovaginal space, basically. So here what I did is the upper vaginectomy, because my goal is basically to resect the vagina anteriorly, and then also to keep it in block with the rectosigmoid, but at the same time is to get posteriorly through the rectovaginal space and centrally. So this is just finishing dissecting the rectovaginal space and the mesentery, anterior mesentery around the rectum to skeletonize the rectum, to transect the rectum with the stapler. Then, so now I went to the proximal portion to further mobilize the sigmoid. And then now to go under the sigmoid colon to create the window so I can get the stapler in and transect the proximal portion. So this is the stapler, which is usually my assistant, through the assistant port. So we'll get it through the window to staple the sigmoid colon at the junction with the descending colon. Then I dissected the mesentery further to get to the distal portion. And now I'm transecting the distal portion with the stapler also. So this is the distal portion with the stapler. So now what I did, I took down the staple line from the proximal portion to put the anvil. So what I usually do, because it's upper vaginectomy, I have the vagina open, so I remove the specimen through the vaginal opening, and I got the anvil through the vaginal opening. So this is the anvil. So I usually do stapled anastomosis. And I use the EA stapler. Usually I like to use 31 or 33 to keep it wide. And this is the other end of the EA stapler through the distal stump. And basically connect them to do end-to-end anastomosis. And sometimes what I do, I reinforce the anastomosis with 3-0 silk, and I'll close the vaginal opening. This patient did very well, and then after surgery, she had chemotherapy and radiation, and she still has no evidence of disease till now, from 2017 till now. The other one I wanted to show is the Da Vinci-assisted hysterectomy and lymphadenectomy, which will be the last one. So basically what I do for all of my cases, I always open the pelvic side wall to identify the ureter, mobilize the ureter, and also at the same time to decrease the thermal injury to the ureter. But also to teach my residents and my fellows how to open the side wall, how to identify the ureter, because it's a good practice to do that. So this is the right side. I'm opening the right pelvic side wall to identify the ureter. Do you know how to make it a little bit faster? Or is it شلون تسرع شوية؟ شلون تخليه أسرع شوية؟ Make it no, okay. So this is the step. I found the ureter, identified the ureter. Okay, sure. So this is the ureter. So after that, I just make a window under the ovarian vessels and dissect the ovarian vessels. And then what I usually do when I get to the broad ligament, I like to dissect the posterior and anterior broad ligament because this helps to push the ureter away. Then this is the anterior broad ligament with bladder flap, with creating the bladder flap. So this is where I want to skeletonize the uterine artery, so I confirm location of the ureter and make sure I'm away from the ureter. And then I take the uterine vessels. And it's basically the same thing on the other side. Same thing, find the ureter and then take the ovarian vessels. And then make the window. One of the things I do not use manipulator for my laparoscopic cases or robotic cases because we worry about the spread of the cancer when you put manipulator in the uterus. But you can tell where is the cervix, and you can dissect around that because usually it's bulbs. And this is the same thing inside the uterosacral and the posterior peritoneum. And this is taking the bladder flap. So this is just to mobilize the bladder. Telephone. You can see this is the bulge, this is the end of the cervix, so you can tell where is the cervix ending. See, that's the end here. So I'm taking the uterine arteries, and what I usually do, I just take one or two bites of the uterine arteries because it's usually avascular after that, so I usually use the cautery after that. This is the other side, same thing. Just make sure the ureter is away, find the ureter. That's the ureter. And basically do the same thing. And take the uterines. And then now I'm just getting into doing the colpotomy. And once you find the vagina, you can just dissect along the cervix. And you don't need any manipulator for that. And then this is the pelvic lymph adenectomy. I'm going to show it more on the other side. But you see, this is the external iliac artery and vein. This is the ureter. And basically, we dissect the lymph nodes. So our limit usually is the mid-common iliac artery proximal, or vessels approximately to the circumflex iliac vein distally. And then laterally is the psoas muscle. And then medially is the ureter. And inferiorly is the obturator nerve and vessels. So we try to take all the bundle of lymph nodes in these areas in patients with endometrial cancer or ovarian cancer. This is for pelvic nodes, and for para-aortic nodes, we start from the mid-common up to the sometime either inferior mesenteric vessels or up to the renal vessels. So you see, this is basically the left side. I'm just dissecting the lymph node of the external iliac vein. And this is the external iliac artery above. And I'm just going under the external iliac vein to open the obturator space, because it's important when you take the obturator node, you need to identify the obturator vessels and the nerve to avoid injuring them. And you take all the lymph node above the obturator nerve. And you see, this is and it's also the tricky part is when you pull the nodes, you're getting into the bifurcation of common iliac to internal external iliac, so you need to be very careful with that because you can end up with injury, and it's really difficult to fix at the bifurcation. And also when you get to the common iliac bifurcation, also you need to be mindful about the ureter. So what I usually do when I get to that point, I usually do a combination of blunt dissection, like we see, and sharp dissection with cautery. That's done with the pelvic nodes. So I'm just going to show a few seconds about the priortic nodes, and then we'll be done after that. So with the priortic nodes, when I do it minimally invasive, laparoscopic or da Vinci assisted, I usually mobilize the right side of the colon, the cecum and the ascending colon, and flip it to the other side to expose the aorta, or incise the peritoneum at the bifurcation to get to the aorta. And you see here's the aorta, and this is the bifurcation of the aorta, and the IVC is on the right side. And then when I go to the left side to get the lymph node, the most important thing is to find the ureter, because you want to just avoid transecting the ureter. So you need to find the ureter, which will be your lateral boundary, and you take the lymph node between the ureter psoas muscle and basically the aorta up to the common iliac, and you take all of this bundle. And you basically move up to the either IMA or to the renal vessel. Usually the artery is forgiving, so you can push on the artery because it has a thick muscle, but you need to be careful with the vein, especially the IVC, because you can end up with a small vessel that will end up bleed. And usually the bleeders tend to retract, so you need to give them good length when you cauterize them, especially on the IVC. That's the IVC here. I think that's the end of this. So the last picture I want to show you . Just want to show you where I work. So basically, this is the Cleveland Clinic. This is one of the building of the Cleveland Clinic. This is the cancer center where I see patients. And this is the main campus. And basically, the main campus, so the Cleveland Clinic has 40 hospitals across Northeast Ohio. But all these buildings belong to main campus. And I'm happy to answer any question. Thank you.
Thank you, Dr. Hyder, for a nice lecture and nice demonstration. My question about the surgical points, but it's not related to the serous ovarian cancer, but it's related to mucinous ovarian cancer. As you know, the approach or strategies for the surgical approach for mucinous is different from the serous. Are there any possibility to sandwich therapy in the mucinous type? I mean, leave the appendectomy, then after 3 cycles, return back to appendectomy and complete further.
So that's a really good question.
It is not standard of care, I know that. It's obligatory in mucinous, appendectomy is obligatory in the mucinous time. But this is a point of difficulties.
Yeah. It's a really good question because we deal with it. I don't treat appendiceal cancer. But it's really difficult cancer to treat because it's chemo-resistant. They don't respond well to chemotherapy.
I don't mention mucinous, I consider the mucinous ovarian cancer.
Yeah, that's what I'm talking about. So the mucinous ovarian cancer is difficult to treat. They are resistant to chemotherapy. We tried to do a trial to look at the bowel regimen, and compare it to our regimen. But we closed the trial early because we could not enroll patients because it's really uncommon cancer, you know.
Yes.
So the way we treat it like in terms of primary treatment. When we do surgery and chemo, we treat it the same way we treat serous carcinoma because we do believe that those patients benefit more from surgery and the heated chemotherapy more than chemotherapy itself. So it's the same thing. If you feel like those patients, you can debulk them, it will be better to do their surgery. And sometimes what we do, we consider heated chemotherapy even if we're doing primary debulking surgery because we know we have data from appendiceal carcinoma that there is some benefit for heated chemotherapy. So I think it's the other way. Surgery, if you can do the surgery for them, it will be better to do surgery first for them, maybe consider heated chemotherapy. And then after that, the first line, we treat them traditionally with carboplatin and Taxol, plus minus Avastin. And then after that, we introduce bowel regimens if they recur. But I agree with you, it's really difficult to treat.
Dr. Haidar, as you know, the mucinous ovarian cancer responding to colonic protocol, not responding well to ovarian serous protocol.
That might be right. But we don't have a phase 3 trial. The idea is we don't have a phase 3 trial that shows that. And
yeah, but this is endorsed by NCC guidelines.
It's part of the guidelines. So you have the option to treat either a bowel regimen or the ovarian regimen. We just reviewed the NCCN guideline a few months ago, and it's basically the theory process is it's hard to say you should do. That's why we keep it as an option. So that's why if you look at the NCCN guideline, it gives you options. And the main reason for that because we cannot strongly say this is better than this, because we don't have a trial that favor one over the other. So you have the option of picking one of those.
But I need more constantly about the patient when you expose as oncologist, as a clinical oncologist, when you expose the patient after coming from the surgical approach with mucinous ovarian cancer without appendectomy.
You mean ovary cancer?
Ovarian.
So they have ovarian, and then you did not remove their appendix?
Yeah.
Oh, that's your question, sorry. So we usually remove the appendix at the time of surgery. But
So you expose this.
if you open the patient. If you do the surgery, we remove the appendix at the same time. But just we remove the appendix. But there is some studies that looked at a mucinous borderline tumor. So there's the borderline tumor, which is the precancer.
Yeah.
And the study showed that if the appendix looks normal, the chance of finding metastasis or abnormality in the appendix is very low. So if the appendix looks normal, if it's an early stage, if it's a stage 1 mucinous carcinoma, or it's a mucinous borderline tumor, you have the option, you can take it. I mean, you can do it even laparoscopic, to remove the appendix, so it's not a big deal. But
Prior to start
chemotherapy.
Yeah.
But if you you have also some studies support that if you decided to keep it in the early stage or a mucinous borderline tumor, if it looks normal, you have to document that you looked at the appendix and it looks normal. You have the option of keeping it based on the studies. For advanced stage, we usually remove it.
Yeah.
Because you need to know for advanced stage, overall, when you deal with a mucinous carcinoma, it's appendix cancer until proven otherwise. So when you deal with the mucinous carcinoma, before you say it's ovary, you have to rule out appendix. So it has to be removed. But early stage, if it's normal, it means it didn't start there. So that's one point.
You cannot go 100% determine this is early or stage 1, even when C. There is rupture, there is cysts, there is.
Sure.
And also cannot determine this is involved or not involved appendix by next eye.
But that's what I'm telling you. They did a study on that. So what they did, they took all patients, who had mucinous borderline tumor or early stage cancer. What they did, who had appendectomy, and they reported whether the appendix looks normal and abnormal. And what they showed that if the appendix looks normal, it's very unlikely to see some disease in the appendix.
This data is a recent passing by CM. Second question about any role of the Avastin with second line in platinum resistance.
Yeah, no, that's a good question. But I'm gonna just say one more thing. For mucinous carcinoma, also we have studies showed that if it's an early stage, it's confined to the ovary, the risk of spread to the lymph node is very low. In one study, it was 0. So we don't feel very strongly about, in early stage mucinous, we don't feel very strongly about doing lymphadenectomy. We do it for all ovarian cancer, but sometimes you can skip it for mucinous carcinoma. For Avastin, it's a standard of care for us, for platinum-resistant ovary, for platinum-sensitive ovary. We have a trial, it's called Aurelia trial. It's a phase 3 trial. What they did, they combined, it's a phase 3 trial, randomized trial. They looked at chemotherapy alone versus chemotherapy and Avastin. And the trial showed that if you add Avastin, you improve response to chemotherapy, you improve progression-free survival, and the patient feels better. You improve the symptoms because there's some data showing that Avastin can help decrease the pleural fluid and the acidic fluid. And potentially, if you dry the fluid, the patient will feel better and you improve their quality of life. So for us, Avastin, especially for platinum-resistant, it's a standard of care in combination with chemotherapy. Especially, these trials looked at first and second line therapy. If it goes beyond that, it's not part of the FDA approval, but you can consider that.
Any study or any data about Avastin after progression? When shift from first line chemo to second line chemo, and patient is still in the maintenance therapy of Avastin with first line and get progression.
Well, so you're talking about you have front line, primary. You get chemo.
This is maintenance therapy.
Yeah.
Okay.
Let me just
get progress.
Yeah. So you're saying primary chemo maintenance, then they finish it, and then it recurs.
Still in the maintenance.
So we don't have.
During maintenance.
Yeah, we tend not to use it. There is a study that just presented in ASCO in June. It's a European study. What they try to answer is if you had Avastin as a primary therapy. So you have primary diagnosis of ovarian cancer. You got the surgery and chemo. You were on Avastin with chemo and then maintenance therapy. And then you developed platinum sensitive. So at least you need 6 months being off it.
No, I qualified about 12 cycles or 16
Right.
cycles of Avastin
Correct.
as a maintenance. And this is gaps crossing the period of early schismatal practices. This will be intermediate or gray zone or platinum resistant.
Yeah, so the trials show that you can use it in platinum sensitive, even if you use it in upfront therapy. You still can use Avastin even if the patient recurs. But we don't have a study, we don't know if progressed on Avastin, we usually don't use it because the patient already progressed on Avastin. There's no point of you trying and exposing the patient to the risk of Avastin again. Sure, thank you.
Thank you, Dr. Hyder. Very nice and impressive, informative lecture.
Thank you.
Really, sometimes we are faced with the secondary tumor of the ovaries, full-converted tumor, and the primary is not known preoperatively. So we proceed for total hysterectomy and bilateral oophorectomy. The next step is.
Yeah. So I'm going to answer it in twofold. Oh, the first thing is, that's a really good question about the unknown primary.
Yeah.
So what we do, and despite that sometimes we also end up with unknown primary, we like to do immunostaining because sometimes immunostaining, and we're talking with Dr. Wahab about that, can help you tease out where is the origin. So what we do, for example, like we have an immunostaining profile. If you are PAX8 positive and CK7 positive, this is point to GYN cancer. If you are CK20 positive and CDX2 positive, this is colon cancer. If you are like TTF1 positive, this is lung cancer. If you're GATA3 positive, this is breast cancer. We have a specific stain for small cell carcinoma specific. These are very helpful because sometimes the histopathology is not very helpful. We have new studies about using genomic sequences, next generation sequences. They can look at the whole genes and can give you a profile. These are not perfect. And we also, despite all that, we end up with having cancer of unknown primary. And what we usually do, two things. We have a clinic called Clinic of Unknown Primary Cancer, and we refer them to those specialists. But in general, we treat them with a common chemotherapy. And usually we do carboplatin and Taxol, because that's a common one, or carboplatin and gemcitabine. And we see what they do on that. The question to resect them or not, we tend not to resect anything if it's unknown primary, unless it's causing symptoms for palliative. So if they have a Crookenberg tumor, big masses causing symptoms, we resect them to relieve the symptoms for palliative reason. Because we don't know if surgery adds benefit, and we tend not to do the full staging or debulking surgeries for them, because we do believe that they are different. And we treat them with chemotherapy and surgery for symptoms only.
And you are working in a team as a surgeon, oncology surgeon, and oncologist?
So I'm both. I'm a surgeon and oncologist. So it's a unique branch because we are the only specialty where we do the surgery and we do chemotherapy, immunotherapy, but we don't do radiation. That's the only thing we don't do.
Yeah.
My group, we are 8 G1 oncologists. And we cover main campus and we cover 2 other hospitals. So we are 8 in main campus, and because main campus is the biggest one. And then we divided 4 cover the east side and 4 cover the west side. And for radiation, we have the radiation group who works with us. But we have our own floor in the cancer center. So this cancer center has different floor. Each floor is different cancer specialty. So our floor is the 4th floor. We work with the breast oncologist in that floor. And then we do our surgeries in the OR, and we have different floor for the surgical cases. For surgical cases, we work with other specialties, because sometimes we work with urology, we work with surgical oncology. Sometimes they need us because especially for pelvic surgeries. For the medical oncology part, we have 1 or 2, it depends on the hospital, radiation oncologists who specifically work with us for that.
And about the heat therapy, other than your center in US or in Europe, is it a shared responsibility, or it is a responsibility of the surgeon to do the heat therapy, peritoneal?
So I can tell you 2 things about my experience as a G1 oncologist. But I also did part of my fellowship. I did rotation with the surgical oncology team, so I know what they do. So for us, it's not. It's our responsibility, So what happened is there is a company. They own the pump, and they come to the hospital. They provide the pump, and basically we develop the infrastructure for the heated chemotherapy. And then we developed our own protocol, and we always revise the protocol. So I tell you, in the past, before this trial, we used to do combination, carbotaxol or carboadriamycin. We use carboadriamycin because also we do heated chemotherapy for recurrent cancer when we do debulking. So we use it for recurrent cancer. So it's our responsibility, but we develop it gradually. Surgical oncology, they don't do chemotherapy, but they are in charge of their own heated chemotherapy. So they use mitomycin C because they do it mostly for mucinous appendiceal carcinoma. And we have a discussion with thoracic people. We're thinking about doing pleural, hipec in the pleural cavity, for mesothelioma and for ovarian cancer. But this is just under development, to look at that. But they are in charge, because it's one drug, they kind of master the dosing for that, and they just do it for an hour.
Haider, any advantage of using cytocidal agents like povidone iodine or chlorhexidine after surgery?
You mean like after surgery? Like we know that chlorhexidine is better. We use it. We switched about 2 years ago to chlorhexidine before. It's better than like iodine. It seems like it lowered the risk of infection.
Not for infection.
Cancercidal.
Complementary for the surgery after surgery.
Where do you apply it? Where do you put it? Like on the skin or inside?
Inside of the peritoneum.
No, we don't have studies on that. We don't do it.
They do have such manner of management in dealing with the GI tumor, especially rectosigmoidal,
Mm.
they do applied bovidin iodine, and they wait for about 5 to 10 minutes, and then they suck and irrigate before closure of the peritoneal
Cavity.
peritoneum.
Is it more for this, just in case there was a spillage of the tumor, or for the bowel spillage, or more,
Yes,
for the tumor?
to deal with the intraoperative spillage and to manage as a on the cytological aspects, not a macroscopical aspect.
Sure, sure.
Yeah.
I don't know if there is, especially for my cancer, we don't do that. The only time we sometimes do it is if you worry about, like if I don't spill, if I do the transection no spillage, I don't put iodine or something. But if there is maybe a little bit of spillage, especially in the pelvis, sometimes we put iodine just because of the spillage of fecal material, not because of the
Not
cancer.
the cancer cells.
No, not
Yes. And associated with postoperative adhesion.
Increase natural.
Increase incidence of adhesion, postoperative.
increase or decrease?
Increase.
Oh, really?
Increase.
Yeah.
Yes.
No, I don't use it.
I
Most
saw-
of us don't use
I
it.
saw patient with massive adhesion, postoperative due to use of stroma.
Mm.
Very, very aggressive adhesion.
Mm. Thank you.
Thank you.
This is what I'm like about. This is what I'm like about.